thanks for tuning in to Beats Research Radio, a YouTube and podcast stream from an active lab at the University of Ottawa Heart Institute. Our goal here at Beats Research Radio is to communicate science and the world of research to the community. My name is Hallie Arnott, and I'm a graduate student in biomedical engineering at the University of Ottawa. And I'll be your host on today's episode. On Beats Research Radio, we are streaming 4 special episodes where we are interviewing women in STEM for International Women's Day. Our guest today is Thais Coutinho. She is a doctor, a cardiologist, and chief of prevention and rehabilitation at the University of Ottawa Heart Institute. She is also an associate professor of medicine at the University of Ottawa. In addition, Dr. Coutinho is the chair of the Heart Institute's Canadian Women's Heart Health Centre. Dr. Coutinho's research program focuses on arterial health with a special emphasis on arterial stiffness and its role on pathogenesis of cardiovascular diseases. She focuses on sex differences in arterial aging and how it may help explain sex differences in cardiovascular diseases. Today, she's here to tell us a little bit about women in cardiology and the cardiovascular diseases in women. So thank you very much, Dr. Coutinho, for joining us here today on Beats Research Radio.
Thanks for the invite. Thank you very much.
So to start off our first segment, I'd like to talk a little bit about underrepresentation of women in cardiology. So despite women being represented now in medical schools by almost 50% in most cases, there seems to be an underrepresentation of women continuing on in cardiology when it comes to fellowships and after medical school. Can you tell us a little bit about why you think that is?
Yes, and I think it's really multifactorial. And I think the approximate statistics are there. 50 to 55% of medical students are now women. Then when you go on to internal medicine residency, that drops to about 46, 47% women, which is still a fairly balanced ratio. But then when it comes to cardiology trainees, as of 2019, the number was about 20% are women in cardiology trainees. And these numbers are already better today than they were yesterday. When you look at women in the cardiology profession, only about 12 to 15% of cardiologists are women. And the numbers can be even worse for the invasive specialties like interventional cardiology, electrophysiology. Then only about 9 to 11% are women. And it's really a combination of multiple factors. First of all, because there are so few of us in cardiology, there are few role models for other women that are considering this career as well.
Right.
You know, when you grow up, observing something, you take that as the norm. So as you're training, in a field that is dominated by men, you have the sense that it may not be the right place for you, which is wrong. This is a great field for men and women.
Right.
The other possibility as well is, cardiology has this image, perhaps, of being a somewhat tough specialty. A lot of call and invasive procedures, a lot of stress sometimes, and acute care. Highly important decisions, life or death decisions. And sometimes some people can stray away from this kind of profession as well if they're perceived to be too intense. And of course, compatibility with families as well,
Definitely,
right?
Yes.
If cardiology are exposed to radiation quite often because of the CAT labs and the EP labs and etc., or CT scanners, PET scanners. Some people just may not want to be considering that exposure as they think about having a career and having a family at the same time. So I think all of these things together have contributed to a small number of women in the cardiology profession.
That's something that's very interesting because you see a lot of women doctors. However, going into cardiology, the fact that it's not a good work-life family balance, or maybe that there isn't enough mentors. However, when women go into the field of cardiology, do you find that they end up sticking with it, and the retention in that field is currently good, or are there sometimes cases where women might start in the cardiology field but then might change later on in life due to different factors?
Yeah, good question. I personally don't know anybody who has abandoned cardiology. I think that by the time, because there's so few of us,
right,
by the time that we commit to it, I think that there's a passion behind it, right? And then
yes, definitely.
for the long haul, I personally don't know anybody who has left. I know people who have dialed back in terms of their work hours. They have done part-time, perhaps assume responsibilities that are less call and so forth, but not abandon cardiology altogether. I don't know anybody who has done that.
Right. These low numbers that we're seeing in with females in cardiology. I recently read an article that was published last year in Circulation from the Monash Cardiovascular Center in Australia, and they mentioned that there was 63% of female cardiologists experienced discrimination due to their gender, and in some cases also due to parenting, in comparison with only 22% of men in a U.S. survey. How does that resonate with you?
Yeah, that is something that is certainly observed. I have several colleagues who have experienced some sort of discrimination based on gender alone. Sometimes some gender characteristics of a female gender can be perceived as a weakness in the field. Women tend to be sometimes perhaps softer and better listeners, and some other traits that can be perceived as a little soft for the profession, which is wrong. This is actually an asset in many ways.
Definitely.
And of course, the parenting as well, like pregnancy and childbirth, do take us away from the profession for a short period of time. As you know, I'm on maternity leave at the moment on my 7th month. And having taken even a maternity leave before, I have come to learn that, 6 months in the life of a person is really nothing, right? To be away. But it is perceived as a weakness to be away for any given period of time. I personally have not experienced direct discrimination. I've actually been very fortunate through my training in the U.S. and also in my career here at the Heart Institute, where I have really been immersed in very family-friendly environments where I haven't experienced this. But that's not to say that doesn't happen. And I certainly know of lots of individuals who have experienced significant discrimination for those reasons.
Right, definitely. So in those cases, what would be maybe a word of advice that you can give to some females who are looking towards going into the field of cardiology as clinicians or looking at that path? What sort of advice would you give them to just kind of get behind them and be there?
Yeah, so I would say that cardiology is amazing. I continue to say that. I decided I wanted to be a cardiologist when I was a medical student, and I never turned back. So that's the first thing I want to say. Cardiology is amazing. And there are so many subspecialties and subspecialties within the field that you're likely to find something that you love and you're going to enjoy working in. My other advice is to find really good mentors, and those can be men or women. A lot of women also are looking for female leaders and female role models, and I think that's very important to have a female role model. And mentors, whether male or female, who are willing to really help you, get to your max potential. When I trained at the Mayo Clinic in the United States, that's a place where there's so many amazing leader females, right? That when you walk around and you're always, rubbing shoulders with this big female, big women in the field of cardiology, you come to learn that that's possible, right?
Yes.
So having that role model is really essential. And my own experience, actually, my direct mentors in research were men. And they're amazing men who have been there for me from the get-go. So arming yourself with this team of amazing role models and mentors is really important for going forward. And I think a good advice is also to ask direct questions. When I was interviewing for this job, which I now hold as a cardiologist here at the Heart Institute, I had an interview, and then I went back home and I was considering my options, and then I decided to follow up with some questions with the chief of cardiology, Dr. Rob Beamans, and I hope he won't mind that I'm calling him by name, but this is a good story. So I called him back and I said, listen, Dr. Leland, I think at the time I was interviewing, I was 31 or 32. I'm just giving you my age now, but I'm 31 or 32 years old. I'm married. I don't have children, but I will within probably in the next 5 years. And I need to know what is the division's perception of somebody like me. I just kind of asked point blank.
Right.
And his answer, without even any hesitation, he said, Thais, family is the most important thing in my life, and I expect that to be yours too. So when I heard that answer, I'm like, okay, that's a good boss. I like to work for this person, and I would like to work with this person or in this division. So that's just an example of, having the I guess the audacity or the courage to ask the right questions to make sure that you're going to find a place that would be a really good fit for you, which I think in my experience has led me to a really good environment where I am now.
Definitely, I'm very happy that you shared that story. That's just such a nice story and comforting story for, I'm sure, a lot of people who will listen to this, to just say that family is important to me, and including that in your work life and including that in the environment at work is extremely important. So I'm glad that you shared that with us today. So have you noticed? So when you had graduated medical school until where you are now, have you noticed any changes between the gender imbalances in the field of cardiology in the medical field that you've been exposed to thus far?
Right. So I didn't graduate that long ago. So medical school, let me think a moment. I'm going to give out my age again. So I graduated school at the very end of 2004, and I started residency in 2005, and I finished my cardiology fellowship in 2013. So just about almost 7 years from now. So it hasn't been that long. Personally, I haven't felt a significant difference as a whole. I have definitely noticed, even here at the Heart Institute, there have been definitely a growth in the number of female colleagues I have now. I think when I started, there were maybe 3, and maybe there are now 8 or 9 of us. So definitely in our environment here at the Heart Institute, things are getting better. But overall, if you look at the most recent statistics, there has been an uptick, a slight uptick in the number of women in cardiology, but it hasn't been dramatic.
Right.
It hasn't been dramatic. I think it's definitely going in the right direction, but we do have to keep sending this message to the female medical students and female residents that cardiology is amazing. Cardiology is perfectly compatible with being a mom and a spouse and being a woman in general, and they should join us. So, because we need to keep bringing more and more women into our field.
Definitely. So, as you were saying, the general consensus of the recent studies, they've been showing that the gender imbalances in this field, it's going to take a couple decades to see gender equality in the field of cardiology. Do you agree with that? Yeah. And what do you see cardiology looking like in maybe 20 years, 30 years?
Yeah, it would take a long time, because if you just think about it, just think of the imbalance there is right now, right? It's 85 against 15%. And just think of the sheer number of trainees coming out every year. It has to be a very gradual change over a long time for you to get closer to the 50-50. Maybe it doesn't have to be 50-50, but it has to be better than 85-15 or 87 and 13, definitely. Right? So hopefully in 20 years, it will be closer to that 50-50. And that's just to say that, women have so much to offer too, because of our own different outlooks on life, let's put it like that, and the way that we approach certain things.
Absolutely.
I think the field has a lot to gain by having more women. So that's what I love to see in 2020, or so not in 2020, in 20 years. It's already 2020.
Definitely. Yeah. So before we go, just some last tips for any medical students who are watching this, or anyone who's even in high school, who are looking up to you and wanting to do exactly what you did, which was go and say cardiology is where I'm going to go and stick with it. What would be your final tips to them?
Absolutely. So study hard, find good mentors, male or female, find female role models, whether it's in your institution or elsewhere, right? You can, we can have role models elsewhere as well. And you find a goal and you just go for it. There will be challenges. There will be challenges for men too. They may be different. There will be challenges, but we can overcome it. And then once we're there, it's really a great field. It has so much to offer. We have so much to offer to our patients. It's a highly scientific field. There's a lot of evidence-based medicine. There's a lot of interventions, whether that's medical work or catheter-based or surgical, that we can offer. We can really make people feel better, live longer within our field. So it's a great field that I really hope that people can see it and join us.
Great. Thank you very much. So the impact you've had on this field and also your outlooks for the field are very exciting. So we're going to have to wrap up here for this segment. And we'll be back with our next segment where we talk a little bit about women's cardiovascular health. So we'll be back in just a few minutes, and we hope you all join us in our next segment.
What are the non-modifiable risk factors for cardiovascular disease? Cardiovascular disease can be caused by a variety of risk factors we cannot control. The older you are, the more prone you are to chronic conditions like heart disease or stroke. However, men have a higher risk of cardiovascular disease earlier in life, while women are more at risk after menopause. Women may also experience different symptoms of heart attack that may go unrecognized. You may be more at risk depending on your ethnicity. People of Asian, African, or First Nation descent have higher rates of cardiovascular disease. Your ethnicity may also influence your diet, which can put you at an increased risk for cardiovascular disease. If you have a first-degree relative who has had cardiovascular disease or a stroke before the age of 55 for men and 65 for women, your risk of heart disease doubles, and regular screenings with your doctor are recommended. But there is good news. Up to 80% of premature cardiovascular disease can be avoided and more effectively managed by taking these proactive steps. Quit smoking, be physically active, eat well, achieve a healthy weight, manage your stress and any anxiety or depression, and see your doctor about managing your cholesterol, blood pressure, and blood sugar levels. For more information on cardiovascular disease, please visit our website.
Beats Radio, scientists interviewing scientists. Canada is a worldwide leader in science and innovation. However, our communities need to be more connected to current scientific research in order to drive the future of scientific innovation. So what steps can we take to more actively engage and connect our community with scientists and vice versa? Innovation and discovery are at the core of the current efforts of our government, but science sometimes gets slightly complicated to understand. At Beats Radio, we will tackle this by having young scientists and early career researchers interviewing scientists and innovators. By dissecting science in simple terms, this will allow our community to better understand the importance of science for our country. Hello and welcome back to Beats Research Radio, a YouTube channel and podcast streamed from an active lab at the University of Ottawa Heart Institute. My name is Hallie Arnott and I am your host today on this episode with Dr. Thais Coutinho. Dr. Coutinho is a cardiologist and Chief of Prevention and Rehabilitation at the University of Ottawa Heart Institute, an Associate Professor of Medicine at the University of Ottawa, and the Chair of the Heart Institute's Canadian Women's Heart Health Centre, which is what we'll be talking a little bit about in this segment today. In our first segment, we spoke a little bit about gender equality in cardiology and the profession just as a whole. Do you think that women being underrepresented in the field of cardiology can possibly impact patient care when it comes to these cardiovascular diseases?
So that's a tricky question. Obviously, men are equally capable of providing excellent care to women. The one interesting aspect, though, is that if you look at the people who are leading the field of women's cardiovascular health, most of these people are women, right? So even though cardiology, as we were discussing earlier, has very few women, the interest in this niche of women's heart health are very often women. I will tell you, as a physician, I trained 6 years medical school and then 8 years of residency and fellowship. At no given point in time in my training did I have particular lectures about the specific or unique aspects of cardiovascular health and cardiovascular disease in women, right? So this is something I had to seek independently. When I was a trainee, I participated in the Women's Heart Health Clinic at the Mayo Clinic, and of course, I've kept up with the field in terms of conferences and papers and so forth. But that's on my own volition. So if the next person, man or woman, doesn't have the same drive, they may not be as aware of the difference and how to deal with them, and therefore the care may be different. The care they provide may be different as well. So I think this is a field where there are definitely a lot of women that are leading it, and talking about it, publishing, lecturing, and therefore it's a great opportunity when it's actually going back even to our previous segment about gender equalities in the profession, this is actually a field where there's a lot of opportunity for leadership as well.
Right. So what you were saying is that a lot of the research, or at least research, is dedicated to women's cardiovascular health, but it's not taught in medical schools as being a possible difference that could occur in practice.
Now, I went to medical school between 1999 and 2004 in Brazil. Definitely, that was never ever discussed. Okay. Then during my residency, we started to hear. And that was, in the U.S. between 2005 and 2013, and that's when we started to hear there were differences for sure. But the overall theme was that women are atypical. Women are atypical. Women are not like the textbook, and women present differently. It's hard. So that's kind of the message, but it didn't go very, very deep, unless, of course, you were to work with some of these experts, which I was able to based on the environment that was to, but it didn't go very far. So even today, I now work with some medical students that do research with me, and some residents that do research with me, and they tell me that there's nothing in the curriculum as well. So obviously when they come and work with me, either in clinic or in the hospital, they end up learning because of course I'm going to be sure to teach them, but otherwise it was not part of their usual pathway. So we're trying to get more people interested in this topic. They shouldn't be interested. Everybody should learn it, right? Because it's half of our population. Cardiovascular disease is the number one killer of women in the world. So we have to. It is our duty as professionals to be able to serve the female population just as well.
Right, so it's being either learned in research or in practice after the fact, which is very interesting. So what are the differences that you would see? Let's say you saw a female patient and a male patient. What would be some of the differences that you would see in presentation of symptoms?
Well, there are many things that are very different. I have a 3-year-old boy, and a 3-year-old can tell you that a man and a woman are different, right? Definitely. So I don't know why it took medicine and cardiology so long to even catch up to this fact. Yeah. And so, we are biologically different from the get-go, and that's talking about sex alone, let alone if you add the dimensions of gender on top of it, then it actually even adds more complexity. But to directly answer your question, let's talk about heart attack or coronary artery disease alone, just to make it simple. I think I would have given you a different answer 2 years ago than I'll give you now. But 2 years ago, I would have said, well, what we hear is that women present with different symptoms. They don't have as much chest pain. They can have pain that is just in the jaw or just in the back or just in the top of the stomach. Or sometimes they just present with shortness of breath as their main symptom. All of these things are true. Men and women can present with these pain just in the jaw, just in the back, or just exhaustion and shortness of breath, for example. But what the most recent studies have taught us and taught me is that the proportion of females and males presenting with chest pain at the time of a heart attack, for example, is the same. It's about 90% of men and 90% of women. Okay. The differences are usually about the actual chest pain syndrome that surrounds it. So, first of all, the classic angina is described as this feeling of heaviness or tightness in the center of the chest or behind the breastbone. Sometimes women may choose different words to express that. I have personally had my share of women that have chosen the word indigestion, even though what they may be feeling may be from the indigestion that they felt before, but they cannot sometimes find another word that defines it better. So sometimes the word that comes out makes it confusing for everybody. Second, what has been shown also in studies is even though men and women have the same proportion of chest pain at the time of a heart attack, women have a greater number of additional symptoms. Right. So when somebody has chest pain, they can have chest pain and palpitations and shortness of breath and sweating and confusion and exhaustion. So when you start to add 3, 4, 5 other symptoms to the chest pain, it makes the situation a little bit less clear. Like the person herself, the woman herself, may not realize she's having a heart attack because she's having other things. Or if this is concerned, she may present to a healthcare provider, and they may now expand their list of differential diagnoses because there are, let's say there's now shortness of breath or palpitation, so they may start to look for other things. So it makes the picture perhaps a little bit less clear than if somebody was saying, I have clutching chest pain in the middle of my chest, and then that would be a so that's another thing that seems to be different between men and women. And most recently, one of the studies that was not published but presented at the European Society of Cardiology just last September, I haven't seen the publication yet. It was very interesting because they use artificial intelligence to actually analyze the conversations between physicians and patients. So these are all patients that were coming in with chest pain to have an angiogram, which is coronary disease. And they were analyzing this conversation with artificial intelligence. Okay. And the bottom line from this study is when you actually let computers listen to patients, the computers will tell you that there's no difference between men and women, right? So the computers will find all of these clusters of symptoms and patterns of symptoms, but there was no statistical difference between the two sexes. So the conclusion, or at least the message that I took home from that presentation of that study, is when you let a computer listen to the patients, men and women seem to be the same. When you let a human listen to the patient, that's when these differences start to arise, because we all come in as a healthcare provider with our preconceived notions and biases about symptoms and prevalences and etc. And sometimes that may make us perceive things as being different, but a computer is telling us they're not different. Exactly. So I think there's more to learn in that field, but that was a very, very eye-opener. So that's why I'm saying that the answer I give you now is different than 2 years ago, because it's an evolving field.
But that's good. That means that the field is continuously learning. And so would this mean that if a woman would come in and the healthcare provider might be a little bit, it might not be as clear that they're having a heart attack, let's say, would the care take longer to get to that person, and that is what results in possibly death or something that could negatively affect the patient?
Yeah, we know the outcomes for, let's talk about heart attack alone. The outcomes for heart attack, for example, tend to be worse in women. Women are less likely to receive all the appropriate medications for the disease. They're less likely to be taken to the cath lab. They're less likely to receive stents or bypass surgery. They bleed more from their procedures. They're less likely to be referred for rehabilitation. So everything is worse. And actually, the 1 year mortality after heart attack is higher for women. Now, I think that time to diagnosis is only one of the many factors. For sure, we always say in cardiology that time is muscle. So the fat and muscle here being the heart muscle, right? So the faster one can get to the diagnosis and to the treatment, the more muscle you salvage, the better your prognosis. So that it definitely plays a role, but there are many other things that are playing a role as well, right? In terms of the science not being there for sex-based interventions or sex-based medications, or also adherence to the best medical therapy for women as we do for men. All of these things contribute to the worst outcomes.
Right. So as you're saying, so learning and practice and also learning from research is extremely important for this field of medicine. And part of your research is dedicated to understanding the sex differences in arterial aging in order to further understand these differences. Could you tell us a little bit about your research and maybe what you know at this point based on that arterial aging between women and men?
Yeah, so I'm very interested in arterial health, and I study the aorta. The aorta is really gives us a good sense of what's happening to the cardiovascular system by actually looking at the function of the aorta. The aorta will show structural and functional changes as all of us age, and that's part of the aging process. But by studying some of these structural and functional and leading to hemodynamic changes, we can tell if an aorta is aging faster than it should be for a person over the particular chronological age. So what seems to happen is during the reproductive years, we all know about all of the beneficial effects of the reproductive hormones in a woman's reproductive age. And for that reason, actually, cardiovascular disease tends to be about 10 years delayed in women as compared to men because of this protection we get over the years. But once women hit the age of 50-ish, which coincidentally or not is the average age of menopause, things start to get different. It starts to be different. So when you look at the aortic stiffness and the aortic hemodynamics specifically, in terms of the pulsatile hemodynamics, it tends to accelerate at a much faster rate in women than in men after that age of 50, to the point that blood pressure becomes much higher, systolic blood pressure becomes much higher in women than in men. And of course, blood pressure is a determinant of so many cardiovascular diseases. So this can have consequences in terms of heart attack, consequences in terms of strokes and cognition, atrial fibrillation, heart failure, especially heart failure with preserved ejection fraction. It's really at the epicenter of all of these different diseases. That's in a nutshell, that's what we see. And it tends to happen around age 50. That starts to separate.
Wow, that's very interesting and very beneficial for the field, I think. In addition to this research that you're doing and being a cardiologist, you're also making a huge difference in the field of cardiology as being the chair for the Canadian Women's Heart Health Centre. Can you tell us a little bit about your role there at the centre?
Yes, it's really it's a great initiative. And I always say that I'm very lucky that I got to jump on the train when it had already left the station. But the Heart Institute, right before I actually joined, was in the process of launching the Canadian Women's Heart Health Centre, which is really a 360-degree comprehensive program to help women prevent heart disease or deal with heart disease. So within this center, we have a phenomenal team, and we have lots of programs that touch upon education of the public. So we have lots of community events. I was just last week speaking at a community event, for example. We have advocacy toolkits to educate the public about women's heart health and then help them become advocates for women's heart health. And also education of providers and scientists. So just in a few short weeks, on April 2nd and 3rd, we're going to host the 3rd Canadian Women's Heart Health Summit, which is a 2-day conference that is dedicated exclusively to women's cardiovascular health. And it's the largest conference in the world, actually, that is fully dedicated to this topic. So this is all part of our center. So in the education piece, we have a lot of things going on. Then you look at research. We have also done a lot of research. Not only do we have lots of researchers within the division that really focus on sex and gender, but since I've become chair and I've been able to work at a broader level at the Heart Institute, we have implemented a number of steps to really foster sex and gender-based research at the institutional level. We have created a toolkit for researchers of basic science or clinical science to incorporate sex and gender-based research at any level of their research program. We have added sex and gender-based analysis to the core of the Heart Institute's research strategic priority. We have added this to the internal grant review. And as a result, we have seen a significant number. I think the number of papers, including sex and gender, coming out of the Heart Institute have at least quadrupled since the center came around. And of course, over 80% of the grants that we are now sending out and proposing to the funding agencies are also going out with sex and gender considerations as a core part of the grant. So that has been also a really huge impact. And clinically, we also have a number of clinical programs we offer to women. From a prevention standpoint, we offer a health coaching program called the Improve Cardio Prevent coaching program, where we work with women that have had gestational hypertension, preeclampsia, gestational diabetes, all of these conditions that actually increase a woman's future risk for cardiovascular disease. And we work with her through a health coach over a course of the year to help her achieve her best health, best cardiovascular health. Check down all those risk factors and really improve their odds in terms of not having heart disease down the road. We have a women's health clinic where we focus on women with unexplained chest pain, spontaneous coronary section, risk assessment, and so forth. And on the rehabilitation and counseling level, Women at Work program is a peer support program, which is so unique because a lot of women, when they actually are diagnosed with heart disease, they feel a sense of isolation, and they feel like they don't know anybody else like them, and they actually have great need for social support, which is not really found in any kind of conventional interaction with the healthcare system. So a Women at Heart program provides peer support to women with heart disease by women with heart disease. And these women are leaders that we have accepted and trained as part of the program. They become leaders and they go out in the community or in the hospital and they start the support programs for women. So these are just a few things. I can talk about it all day that we're doing. So it's really a comprehensive program to really improve the health of the women in our country.
Wow, that's absolutely amazing. You that last question, you really touched on everything that Canada, the Heart Institute, and cardiologists, female cardiologists, and also the male cardiologists are working towards for a better future for medicine for women. So thank you very much for joining us here on Beats Research Radio. I learned a lot from you today.
Thank you very much. Thanks for having me. It was great fun.
Great. So I'd like to also thank our sponsors, the University of Ottawa Heart Institute, eLife, the Canadian Biomaterials Society Ottawa Student Chapter, the Beats Research Lab, and the Department of BMI at the University of Ottawa, who are all supporting us here. And behind the controls today is Alex Ross, and our director is Dr. Emilio Alarcon. Thank you for tuning in, and we'll catch you all next time. Beats Radio, scientists interviewing scientists. Canada is a worldwide leader in science and innovation. However, our communities need to be more connected to current scientific research in order to drive the future of scientific innovation. So what steps can we take to more actively engage and connect our community with scientists and vice versa? Innovation and discovery are at the core of the current efforts of our government, but science sometimes gets slightly complicated to understand. At Beats Radio, we will tackle this by having young scientists and early career researchers interviewing scientists and innovators. By dissecting science in simple terms, this will allow our community to better understand the importance of science for our country.